to do with PCOS, which is, I've forgotten what it is now. I've actually forgotten. I can't remember what it's called. Let's just ask the doctor. What is it? What is PCOS?
So it stands for polycystic ovarian syndrome, and it's a diagnosis that's made off of 3 different things. So it's made in women who, if they had a scan and on their ovary they had lots of little cysts on them, so lots of little follicles, then that would be a polycystic ovary. But you get the syndrome if you have a regular period. So say some women would have a period every 3 or 4 months, something like that. So they would meet that criteria. Or if they've got acne, or they've got hair growth on the chin, so sort of male pattern hair growth. And then lastly, on a blood test. So if in your blood it looks like you've got sort of a higher testosterone, or some of your hormones look a little bit imbalanced, so then that's how you come up with the diagnosis of polycystic ovarian syndrome. So you have to have 2 of the 3 for it to be that.
So my next question was going to be, what are the symptoms? But it looks like we've already covered that. So as you said, hair growth and through blood test. And did you say scan?
Yeah, so scan on the ovary. But for you to get to that stage, it might be that you've got a regular period. So a regular period is probably the first symptom that you'll see, as well as the hair growth and acne and things like that.
And is it treatable?
So there's no cure, so to speak. It's manageable, and again, you manage the symptoms for where the woman's at in her life at that point. So in a young woman who is having irregular periods and that's her main concern, then you treat her with the pill so that you regulate her period. And if it's a woman who wants to have a baby, because PCOS can affect your fertility. So if it's a woman, and it affects your fertility because if you're not having enough periods, then you're not ovulating enough. So if you have 5 periods a year, it's likely that you've ovulated 5 times that year, and that's quite hard to capture if you're trying to get pregnant. So then for those women, they might be put on medication to increase their rate of ovulation, or go through the process of IVF. If it's acne, then you can give them the pill that can help with the acne, or you can give them laser treatment for hair removal. So that's really it. The biggest thing with PCOS is weight loss and exercise. So there'll be some, skinny women who have PCOS, and it might not necessarily apply to them, but if there is a high BMI concept with it as well, then weight loss is probably mainstay. Like I've had patients who have PCOS, you get them to lose a significant amount of weight, and then their periods are all of a sudden normal without you needing to treat them, or they can all of a sudden get pregnant without any intervention. So weight loss is definitely mainstay. The risk factors with PCOS is diabetes in pregnancy, diabetes in later life, and again, weight loss is going to be your mainstay treatment for those women to prevent that. And then lastly, one of the things we worry about in these women is that they're at risk of endometrial cancer. And this happens because if you're not bleeding at least 5 times a year, the lining of the womb, which we would ordinarily shed monthly, is overgrowing. And if it is allowed to overgrow without us bringing on a period, then you might find that the cells in the lining of the womb can become cancerous. So for those women, it's important that we monitor them, give them a Mirena or put them on a pill, but just something to make sure that the lining of the womb is healthy.
For women who might find out, or young women who might find out they have polycystic ovaries and choose to perhaps go on the pill to help regulate it, does that, in terms of going on a pill, would that affect them later on in life if, say, they want to then have a baby, or does it not affect them at all?
So, it does. So all the research that we have on the pill and fertility is that it doesn't affect it at all. There is one version of contraception that might delay return to fertility, but we don't use it that often anyway. But the pill, the Mirena, if anything, well, they don't help with fertility, but they definitely don't prevent it. And we do know that if you stop taking the pill, the combined pill anyway, the month after, your body probably more ovulatory because it's sort of kicking itself into gear. So no, it doesn't affect fertility. And it's definitely a well-held myth in our community that if you take the pill, take contraception, you won't get pregnant later. You know, the chances are women who have fertility issues might have had them before the pill anyway.
Yeah, and that actually leads us straight into the next topic, which is actually to do with fertility.
Yeah.
Now, the question I wanted to ask was, what is the main reason people struggle with fertility? I feel like it's something that's not really spoken about, and especially like around our age, or people who just got married and from a culture and background, they're like, oh, where's the baby coming? Oh, where's the baby coming? I feel like they completely forget that you might be having problems, or
Yeah.
it's just okay, you're married now, where's the baby? So I just wanted to ask, my first question is, what's the main reason people struggle with fertility?
Oh, I think it's a hard question to answer, because women have fertility issues for different things. The main cause of infertility, so to speak, is unexplained infertility. So there's a large proportion that they'll go through all the tests, the partner will go through all the tests, and they still won't know why. So that's a large proportion of it. The different causes of it, however, that exist, I can go through. So untreated sexually transmitted infections. So untreated chlamydia or gonorrhea specifically can damage the fallopian tubes, which means that it's hard for an egg to go into the womb, to meet a sperm, to fertilize and implant. So that's a huge cause that I don't think a lot of women are aware of. And it's partly why the government introduced yearly chlamydia screening swabs, which you can get done through your GP or even a chemist, and Superdrug, I think, do them. So that's a cause of it. Another cause of it is older age, like women are getting pregnant later on in life. And sort of your peak fertility, I'll never forget seeing this in med school, is really around the time that a lot of us are finishing uni, starting jobs and things like that. So that is when you're most fertile. And then the next peak is sort of 25 to 30. And then 35 onwards, it's like a very steep decline. And you never really know where in that bracket you would sit, because, you know, no one knows how fertile they are. And then unfortunately, about 1% of women go through premature ovarian failure, where they go through the menopause earlier, so less than 40 years old, and that affects around 1% of women. So in that group, again, you don't know that you're that woman until it happens. And then I think just other things that can affect your I guess your ability to get pregnant is knowing when you're ovulating and having sex regularly around that time. And the advice is, if you're having sex 2 to 3 times a week anyway, you'll catch your ovulation date and your ovulation period. And now they say go to your GP after a year of trying, and they know that because at least 92% to 95% of couples would get pregnant on their own within sort of 18 months of trying. So I would say, like thinking of a young, say, African couple or a black couple that just got married, you know, are you having sex often enough? Are you capturing the ovulation window? If a woman is having a period every month, it's assumed that she's ovulating every month. So then the issues then might be the tubes, it might be that the sperm is affected. You know, there are so many reasons, but there are also couples who both of them are fine and they're just not getting pregnant, and then seeking help early, going to the GP, getting on the IVF waiting list, like that's also a very legitimate way to have a baby, and it's nothing to shy away from. And I think that's, you know, that's also worth saying, like, and I don't see why it is so shrouded in mystery, but again, it must be cultural.
Yeah, I definitely think it's cultural, because yeah, I don't know why, but I guess it just is. I think you touched on quite an interesting point there, which was untreated STIs, and I think if people would be able to be like, oh, maybe I had an STI and I didn't know about it. But it just made me think that people should, if you are sexually active, then, you know, get checked regularly to make sure everything's fine, because you don't want to find out down the line where you are ready to have a child and then find out that it was, you know, an STD you had in, I don't know, 2004 or something. So another thing that I've culturally noticed, right, this might just be me, but this is what I think I have observed, is that when, let's say a couple can't get pregnant, it's usually assumed that it's the woman's fault, or they assume it's their fault. Why do you think this is?
So again, I definitely think that's culture. I think, you know, like even to the basis of sex definition in a embryo or a fetus, that's down to the male sperm that attaches to the egg. Do you know what I mean? Like, you know, it's also a cultural thing that if a woman can't have a boy, it's the woman's fault. Whereas scientifically, it's not. It's the man's fault. And you know, and even just, I think, I don't know. I'm not to sound like I hate men or whatever, but like, I just feel like women take the brunt of everything. You know, like making a baby is a two-way street, and it needs an egg and good sperm for it to happen. And the same way that a woman could have her fertility affected by an untreated STI, so could a man. And, you know, there are lots of men, you know, I know there's a high percentage of men, even in Nigeria, who have male factor infertility because maybe they do sleep around and they've got an infection in, you know, in one of the pathways that creates good working swimming sperm. So, yeah, I mean, that part of the culture definitely infuriates me. And I just think, I mean, it's 2020 and we're learning a lot this year, but it's also just to say, like, if fertility is an issue for you as a couple, then you as a couple go to the GP and you as a couple get tested. It is not one person's problem. And then you have to, as a couple, accept the outcomes of that investigation. So even if it is female factor or male factor, it is both of your problem and you deal with it together. Like, I just don't see how it then becomes one person's issue to shame them with. But yeah.
I completely agree, because even you saying that, I do feel like even women themselves, maybe it's society and the way that we've grown up, not just culturally, but where you are in the world, really. I think that women carry that burden themselves as well and say, oh, it must be me, you know. So yeah, I like the fact that you pointed out that you deal with it as a couple. You enter this together, and you know, and if this is what you want, then deal with it together rather than shaming one party. Because if it was the other way around, I would hope that you'd want to support the other person in the same way, because it's one journey with both people. My other topic that's linked to fertility is miscarriages. So I have recently, because I work in a lab, I don't know why, but I've recently just noticed that when I'm like releasing results, I'm just seeing pregnancy of unknown location, miscarriage. And I don't think I realized how common miscarriages actually were. So can you just elaborate a bit on what I've said about how common it is, and perhaps how people should deal with it?
I mean, the dealing with it is a tricky answer, but I mean, so miscarriages, we know, or we work under the basis that miscarriages affect 1 in 4 pregnancies before 12 weeks. So this is from missing a period, having a positive pregnancy test at home, sort of to the 12-week mark. It could be about 1 in 4, and and it's common. And I think as a doctor, as a medical professional, because I see it so often, I'm quite desensitized to it. But however, it's still very precious to the woman involved, if that makes sense. And it could be just a positive pregnancy test, or it could be seeing baby on a scan, having a heartbeat 1 week and not having it the other. The largest cause of miscarriages in the first 12 weeks are due to sort of the genetics of the embryo. So it just, something has happened, or it's fused joined in a way that it's not compatible with life. And I guess it's, nature or your body sort of taking its course. So they are common, but that doesn't, like, I'm very careful to say, I know they're common, but I feel like for the woman involved, it's not. And I don't know, because I've never had one, but I've come across with patients when they're having miscarriages, and sometimes it can be quite, you know, depending on how involved I am with the case, it can be quite heartbreaking. I know women who've had miscarriages, and for them it's heartbreaking. And it's just like, be kind with yourself if it happens. Take the time you need. We speak a lot about postnatal depression, and these women go home with a baby, right? And the hormones are all over the place. But a woman who's had a pregnancy for 12 weeks, her hormones are all over the place. And then when she loses that pregnancy, her mental state is just as precious, if not more. So I do feel like we probably need to be a bit more sensitive in how, you know, women who do have miscarriages go on to recover, and then the mental state they go into their next pregnancy with as well. And you know, and so take the time you need, go to your GP, and most GPs should be able to give sick notes, and like, just take it easy, I think is typically my advice on dealing with it. And again, we've got this thing in our culture that, oh, you don't tell anyone you're pregnant until you're 12 weeks, because if you miscarry, then you have to tell them you've miscarried. And miscarriage in itself is not even a taboo. It's a place of vulnerability. And if I've told my closest friends that I've miscarried, they are my support system when I'm going through, like, that I'm pregnant, sorry. They're my support system if I miscarry. And I think, again, it's coming out of that behavior that, oh, I can only tell people I'm pregnant when I know I'm going to have a baby at the end of it, because you don't. And I think not to put anxiety in anyone's heart, but you know, we know that common miscarriages happen by 12 weeks, but between 12 and 40 weeks, anything can happen, and miscarriages still happen at that point. Stillbirth still happens at that point, or, you know, and it's a lot. It's a lot, and it's a lot emotionally. And I think ultimately you want your support system there with you. And if it means telling people when you're 6 weeks and then you tell them the next week that you're not pregnant, then at least they can support you. They can buy you food, look after your children, like, you know, so just find ways to look after yourself. Pregnancy's tough. And for the majority of women, it goes without a hitch, but there are some women it doesn't go well. And even on the labour ward, there are still really disastrous outcomes out of anyone's control. So yeah, you know, you want to go into it with faith and positive thoughts, but you want your support system in case it doesn't go well.
It is really, really common, and one of the reasons I brought it up is because I feel like people don't talk about it enough, and I just wanted to bring it up. Like, it's normal, it happens a lot. It's fine to talk about it. It's fine to grieve about it. It's just fine to, you know, like, if that's what you want to do, talk about it, grieve about it, take some time out, then it's all fine. Because as you said, 1 in 4 women, that is such a high percentage. So your friend over there has probably had one and you don't know about it. So yeah, if you need someone to talk to, maybe you should just talk about it. Okay, so my other question, I didn't know this actually, but I was speaking to a friend who told me that she had a miscarriage, and this was the second time that she's had a miscarriage. But I actually didn't know that after the 3rd miscarriage is when it gets investigated. So I wanted to know why this is. I thought it was after 2, but apparently it's after 3. Why is this?
I guess why it's after 3 in the UK might be resources. Who knows? I don't, you know, but the investigations they do probably wouldn't change if they did it after 2 either. I think the issue is because 1 miscarriage is quite common, they wouldn't do it after every miscarriage. But whether they do it after 2 or 3, you know, it's more emotionally telling on the woman, isn't it? Because she's having to wait. So it's probably better done after 2. But the tests are hopefully to get results that will then guide how they manage the next pregnancy, so that you then get to a point of viability. So that's the aim of it, really. And there are times that women go through tests and there's no cause found, but then still they get all the support and all the extra treatment in order to prolong the next pregnancy and see if it works.
So what kind of test would be like the baseline to start off to find out why someone's had a miscarriage? What's the first line of investigation?
So it depends how the miscarriage happened. So if they're all like early 12-week miscarriages, so what they would do is on, say, the third miscarriage, I, as a doctor, would send that off for genetic testing to see why that had happened, to see if there's a genetic mismatch in either mum or dad that's causing that to happen. And then other tests that we do are blood tests. So we look for, say, antibodies, see if they've got lupus or they've got a version of lupus or they've got any other condition that causes them to clot a lot and things like that. So those are sort of the mainstay tests. If a woman got to, say, the second trimester and delivered a baby because the cervix was weak, then in her case, at her next pregnancy, you might just check how the cervix is holding up. And when you think it's becoming weak, you can reinforce it with a suture, like a stitch into the cervix. So that's another way of managing it. But the testing itself is typically blood tests, genetics, and things like that to see if there is a cause that's causing you to miscarry. Because there are groups of women who have clots or clot more easily, and those women often struggle with miscarriages, and they get given blood thinners in the early pregnancy, and they get given reinforcement with hormones to get the pregnancy into sort of the second trimester at least, and then get more support at that point if it's needed. So that's the baseline test, and the tests are all to manage the next pregnancy quite early on.
Well, thank you so much, Remi. This comes to an end. I know I asked I probably have a million more questions to ask. I think we'll end it there, or else we'll just be here forever. I just want to finish off by asking you if there's 2 pieces of advice that you can give about concerning women's health. What would it be?
So I think it would be to know your body, educate yourself and know what's normal, so that when something is abnormal, you can act on it quickly. And I would say to seek help early. So if you've got any doubt, or if you just need something checked by somebody, then I'd say seek help earlier. So those would be it. And just don't be afraid of doctors.
Thank you so much. That is great advice. Thank you so much, Remi, for coming on here and sharing your nuggets of wisdom as a doctor and about women's health. And I hope someone gained something. But I know that I personally learned a lot. I thought I knew bits, but I obviously didn't. So I learned a lot, and thank you so much. And I put a link down below of their page. It's called Chat Her Box, and you guys can follow. I might put a few NHS links as well about the topics that we've discussed today. So if you guys need more information, you can go. And also, you said that I think on your page people can like email you, right? Or
we're happy to have questions. Obviously, it doesn't replace medical advice, and we will always caveat with going to your GP. But we're always happy to answer sort of generic questions and to help with anything. But thank you so much for having me as well. It was really fun.
Thank you so much for coming. And this will be the end of today's session, and we hope you will see you back here again next week for another interesting topic. So bye.